Second part of the voiceover for the Burns lecture. And in just an important component to remember about narcotics is make sure that it's not being given IM, because we know with the tissue loss there's poor absorption or alterations in absorption. So make sure the narcotics are to be given IV. So some other things to consider with drug therapy is VTE prophylaxis, so the prophylaxis of DVTs. We know these patients are at risk for it because of the hemoconcentration, with the increase in hemoglobin and hematocrit, with the fluid loss. So when it's appropriate, we might consider low molecular weight heparin or Lovenox. But if the patients are at increased risk for bleeding, their H&H drops as they're resuscitated, maybe they have a DIC component to the burns, we're going to do other methods of VTE prophylaxis, such as the sequential compression devices, compression stockings when indicated. So nutritional therapy. In the beginning stages of the emergent phase, we know fluid volume replacement is the hallmark treatment, but we're not going to wait too long to start feeding these patients. And the priority feeding method is going to be enteral. We know enteral is better than parenteral always because it's more physiologically sound with the patient's body. So we're going to do early and aggressive nutritional support, within hours of the burn injury. It has found to decrease mortality and further complications. It's going to improve and optimize wound healing. We need to keep these patients in a positive nitrogen balance because their resting metabolic rate is somewhere between 50 to 100% above their normal. Although these patients are at risk for hypothermia and their surrounding tissues are low temperature, their core body temperature is elevated, they're in a hypermetabolic state. So in order to keep them in a positive nitrogen balance, to optimize wound healing, tissue regeneration, these patients are going to need somewhat in excess of 5,000 calories a day. So even if they are able to take things by mouth, they're not even going to be able to meet those demands. So we're going to put in a core pack. We're going to put in a small bore feeding tube, and we're going to feed these patients enterally. Unless there's an obstruction or if there's some reason that enterals is contraindicated. Early continuous enteral feeding. We may do supplemental vitamins and other nutrients as indicated. All right, so as we move from the emergent phase into the acute phase, this is going to be when mobilization of the extracellular fluid starts and that there's going to be subsequent diuresis from the kidneys. The acute phase is going to conclude when the partial thickness wounds are healed and the full thickness burns are then covered with skin grafts. So if the diuresis starts or commences, these patients are going to start to lose their swelling, their edema. Hopefully bowel sounds have returned if these patients have developed a paralytic ileus. And we hope that healing starts to occur around the site of the burn injury. So with some patients who have got the deeper or the fuller thickness, we hope the necrotic tissue starts to slough, that granulation tissue forms. The eschar needs to be removed, and then the skin grafts are going to be replied, especially if this is the full thickness wound. So some of our laboratory values, we set in the initial emergent phases or even in the earlier acute phases, these patients are at risk for low sodium. It's because sometimes the sodium actually moves into the extracellular, moves into the interstitial out of the intravascular space. But we can also have low sodium related to other things, such as water intoxication, maybe excessive GI suction. So if they have a nasogastric tube to decompression, we might make them hyponatremia. If they're having diarrhea, so other things to consider with low sodium. So hypernatremia, this may follow once the hyponatremia has subsided and these patients' fluid has remobilized and the diuresis has commenced. Oftentimes we're going to see the hypernatremia from the treatments that we give these patients, whether we give them too much IV fluids that have sodium, or sometimes the tube feedings have a higher sodium concentration, or at least they're unbalanced in proportion to the free water that they're going to have. So we need to make sure if they do have hypernatremia, because there's always potential complications and signs and symptoms of high sodium, we're going to restrict the sodium that's in their IV fluids. And we also might start giving them water boluses throughout the day to kind of offset the elevation in the sodium. Hyperkalemia, so elevated potassium, is a big finding in the early stages of the emergent phase. And that's because of the crushing, the tissue loss with the burn. So we've got the release of potassium from the cells. But we can also see hyperkalemia if these patients develop an acute kidney injury related to the myoglobin that's been released from the muscle damage. We know with elevated potassium that it increases their risk for cardiac dysrhythmias, bradyarrhythmias, block, and even cardiac arrest with, like ventricular failure. So some other things we might see is the muscle weakness. And if we're really looking at some ECG changes with elevations in potassium, we know there's going to be a widening PR interval, there's going to be a widening QRS complex, and we're going to see peak T waves. So mostly the potassium we see is going to be related to the muscle damage from the significant burns, but we also can see it from an acute kidney injury. It's going to be an ongoing hyperkalemia. So these patients with hyperkalemia, although we may not treat them with Kayexalate, I think we're still going to support them as far as maybe calcium gluconate to kind of protect their myocardium. Other maybe temporary measures, if they're acidotic for whatever reasons, we might consider sodium bicarb. But we need to make sure if our patients have hyperkalemia that they're going on the monitor. They're going on the ECG, continuous monitor. We're monitoring for those ECG changes, any types of dysrhythmias, arrhythmias that indicate failure, arrest. So hypokalemia, so on the other end of the spectrum, if once these patients, the fluid mobilization starts to balance, we might see potassium start to be excreted, especially with the diuretic phase. When these patients start to diurese, fluid remobilizes. If there's excessive vomiting, diarrhea, or if these patients are have an NG to decompression, suction, we might be losing potassium that way. So vomiting, sweat, diarrhea, those are the biggest areas where we actually lose potassium from. So some other complications, like we talked about, is wound infection. So we need to make sure that we're monitoring for the presence of infection, some other signs and symptoms, although we might see both hypothermia and hyperthermia. Their metabolic rate is high to begin with. So sometimes body temperature may not necessarily be a good indicator of infection with these patients. If they truly are, if it's becoming more systemic, septic, we are going to be looking at elevations in their heart rate, respiratory rate, low blood pressure after, they've been volume resuscitated, after that initial phase is over. And then we're also going to look at target organ function. If there's a decrease in urine output, that lets us know if we've got adequate perfusion or not. So there can be some neurological changes with our patients with burns. It may not necessarily be related to the burn itself, but some of the secondary, the complications from the initial injuries. If they have inhalation injuries where we suspect hypoxia, if it's related to the IV narcotics, maybe it's related to the electrolyte imbalances. Some of the other things we're concerned about, contractures. So we're going to start increasing the range of motion as appropriate as possible, early as possible. We're also worried about paralytic ileus, so we're going to be monitoring the GI system. Curling's ulcer or stress ulcer related to maybe hyperperfusion in the early stages of burns, especially if they're low blood pressure hyperperfusion to the gut. So it can lead to ischemia and alterations in the gastric mucosa. So these patients can develop ulcers. Okay? So some of the same other things that we're going to see with any other ulcer, hematemesis, maybe some dark tarry stools, drop in H&H. Okay? Maybe some of the NG drainage that's coming back looks a little coffee ground. These patients are at increased risk for hyperglycemia. They're in a hypermetabolic state, but they're also having like a stress response. So their sugars might be elevated. So our goals of wound care is obviously the prevention of infection, whether it's a translocation of normal flora or whether we've cross-contaminated from another patient. And we also want to do our best to promote wound epithelialization. So we might consider some agents for enzymatic debridement, and we know keeping the wound bed clean and without infection, remove of any of the necrotic tissue is going to speed up healthy wound bed tissue growth. So some other things to consider, appropriate coverage of graft. Okay, so gauze is going to be next to the graft, followed by the middle and outer dressings. We're typically going to see unmeshed sheet grafts used for facial grafts, and the grafts are going to be left open. Some of the complications from them include blebs. Some other things to consider with excision and grafting on the grafts is the eschar is going to be removed down to the subcutaneous tissue and the fascia. The graft needs to be placed on clean, viable tissue for it to take. The wound is then going to be covered with the autograft. The donor skin is taken with a dermatome, and the choice of dressings afterwards varies. The grafts are going to be attached with a fibrant sealant or sutures, staples. With early excision, function can be restored and scar tissue is minimized. This is just a picture of a split thickness sheet graft to a hand. And this is an image of a donor site being harvested for graft. So some other considerations with excision and grafting. Some of our cultured epithelial autografts are grown from biopsies obtained from the patient's own skin. It can be used in patients with a large body surface burn and those with limited skin for harvesting, or those with limited skin for harvesting. So there's artificial skin with life-threatening full thickness or deep partial thickness wounds when conventional autografting is not available or auto-advisable. So it consists of both dermal and epidermal elements. So some things to consider too in the acute phase. Our patients we know with burns are going to be having a lot of pain. It's going to be associated with treatment, and then it also could be continuous. So they're going to necessarily be with the IV narcotics in the initial phases, but gradually they may be on extended long-term release opioids. Some instances we talked about, if there's a lot of anxiety or apprehension about wound care, they're not only going to receive the analgesic, but they also can receive the sedative, the anxiolytic. We're also going to consider some of the non-pharmacologics, like the relaxation techniques, guided imagery, music therapy, aromatherapy, visualization, just to kind of synergistic effects to help us maybe reduce some of the amount of pain medications we're giving these patients. We're also going to be starting range of motion therapy, physical and occupation as soon as possible. We talked about nutritional therapy, but this is going to continue because we want to meet their daily caloric needs so that we can continue good wound healing. So we're going to be collaborating with a dietitian. And once these patients start taking foods by mouth, we want to make sure it's high protein, high carbohydrate foods, high caloric. And we're going to be watching their patient's weight, body weight. And we're also going to be looking at some of those other diagnostic tests, albumin, maybe pre-albumin, iron panels. So in the rehabilitation phase, this is where the wounds have healed. The patient starts to hopefully engage in some level of self-care. Hopefully over time with their wounds, the discoloration of the scar is going to fade. Sometimes the pressure can help keep the scar flat. And the newly healed areas can be either hypersensitive or hyposensitive to cold, heat, and touch. A lot of the healed areas need to be protected from direct sunlight for about 3 months. And we talked earlier about the risk of skin and joint contractures. So they're some of the most common complications during the rehab phase. We talked about the extremities, making sure that they are in more extension. We're kind of keeping the arms out, the fingers out to maintain them in that extension form. We talked about any types of neck burns, minimizing pillows, watching ears, but we want to make sure to minimize any contractures, joint contractures. We're paying attention to positioning, splinting, and exercise that's going to be used to minimize contractures. So we also want to encourage participation in self-care, informing, educating them about skills for dressing changes, using water-based creams because that can help maintain healing and also keep the skin from avoiding it from being dry, maintaining elasticity. Sometimes reconstructive surgery is going to be needed after a burn. There's going to be an importance of not only isotonic, but maybe isometric exercises, passive, active range of motion. And we always want to make sure that we're encouraging and being positive, reassuring our patients. We know that we talked about burns is considered a preventable injury, but we know high-risk patients, our gerontology population, they have unsteady gait, maybe limited eyesight, decreased hearing or sense of smell. All of them put them not only at risks for fires, but also risk of injuries associated to the fires. And we know related to some of the skin, the integumentary changes as they get older, sometimes it's going to take a little bit longer for the wounds to heal. And they also have, as they have loss of muscle mass, alterations in subcutaneous placement, they're also at risk for, more of the hypovolemic repercussions because even a small amount of fluid loss is detrimental to these patients. And the emotional needs of the patients, like we said, we want to be positive, reassure, assess the circumstances of the burn. Sometimes burn survivors, if other patients have succumbed to their injuries, they might be feeling a little bit guilty, frustrated. Once they've kind of got through the emergent and the acute phase, some new fears and anxiety might start to arise during the recovery phase, as far as engaging back into society, back into their maybe the workforce. So their self-esteem, self-concept may be negatively affected. So we always want to be looking at the patient holistically, focusing on their spiritual and cultural needs. Obviously, sexuality will be an issue ongoing. We always want to make sure that we're engaging family and patient support throughout this patient's recovery.